We're gonna start the meeting. I'm sure there's a couple of people late to join, but they can review the recording after we are done. So I just wanted to take this time to introduce Rabia Khan. Do you want to go ahead and introduce yourself?
Hi everyone, I'm Rabia Khan and I'm based here in Sydney, Australia, and it's just after midnight here, so I'm a bit worse for wear kind of thing, but I will stay awake till the next hour. I'm a epidemiologist by background and mostly in public health. I've been working now for 20 years, and I've worked in New Zealand, Australia, UK, and in France, in Paris, at the OECD. And the presentation you're going to watch is about the work I did in the OECD. And more recently, I've been involved in the COVID response, nothing to do with aging, nothing to do with patient-reported measures, what you're listening in this presentation, but more about, I was doing more your shoe leather epidemiology with the COVID response here in Sydney, Australia. So enjoy the presentation, and I'll be here for questions afterwards. Thanks.
Thank you, Rabia. Hamza from the Office of the Secretariat will now share her screen and we will watch the great session video live. Do you hear audio?
We do not.
No.
No.
Hamza, you want to stop sharing and then reshare? And when you click on share, make sure that you click on audio. I'll just pull up the video as a backup in case it doesn't work. No
And
worries.
you have to keep your volume on, Hamza. Otherwise, we can't hear it.
Can you hear?
Yes.
Leave your volume on, Hamza.
In these unprecedented times, my name is Rabia Khan. I'm based here in Sydney, Australia. At the moment, I'm working for the George Institute for Global Health. I'm a public health specialist or epidemiologist by background, but today I'll be speaking on mental health patient-reported outcomes, which is measuring outcomes from an older person's perspective. And the reason I'm chosen this topic to speak about is the last few years, especially when I was working at the OECD in Paris, France, I was developing mental health patient-reported outcomes. So this is a way of sharing that experience and knowledge. So what am I going to talk about in the next 10 minutes? So I'm trying to cover three main things. So basically, firstly, what is people-centered mental health care? Why measure it? So why measure what matters to patients and from the patient perspective? And lastly, how do you go about measuring mental health outcomes? What does it mean for a practitioner to be measuring these? So what are people-centered mental health care services? So the concept of integrated people-centered services has become influential across the globe. So it's not just one country, or it's just high income or middle income or low income. It's taken on a very global perspective. So we'll start. So starting with the definition, and this is the WHO, the World Health Organization definition, and it says integrated person-centered healthcare is an approach to care that consciously and continuously adopts perspectives of individuals, families, and communities, and see them as participants as well as beneficiaries of trusted health systems that respond to their needs and preferences in a humane and holistic ways. There's a lot of words in there. There are a lot of constructs and concepts in there. But what it means is shifting from a biomedical perspective of delivering healthcare to a more person-centered perspective. So what does that mean in mental health care? So in mental health care, it means shifting from services that are very much based out of a psychiatric unit or a public hospital to more community-based mental health care. So it fits really well with with what TUFH is trying to do, and what a lot of people here are interested in is how do we shift to a community-based mental health care. That's one of the big components of a people-centered mental health care service. And secondly, it's about a recovery-oriented practice. So it's about how do we get people back to being at work, back to being at being with their families. So how do we move people back into the community? So one of the key things within people-centered mental health care services is about promoting individual agency, choice, social inclusion, shared decision making. So it's really informed by the human rights agenda, that the care that a person receives is about what they want and what they need. And especially from an older person's point of view, it's really taking into account that what are the needs of an older person. So not every single person in our community or in our healthcare system is treated the same. There are different needs, especially mental health for children and young people, for the general adult population, and for older adults. So there are those needs, and how do we make sure we match and we meet those needs? So as I was saying, people-centered healthcare has gone quite global. And so the conference on primary healthcare recently in Alma Ata, that was about how do we promote people-centered healthcare, and especially integrated. Same for Health for All in Tokyo, the OECD Policy Forum, which was their main agenda was on people at the center of all healthcare decision, as well as the Lancet Commission, the High Level Commission on Health, Employment and Economic Growth. So there seems to be a lot of, the stars are aligning, and a lot of people are realizing we need to take a human rights approach, and we need to take a person or people-centered approach. So it's the individual, the family, the community. How do we make sure the health systems around them? Because I think at the moment, a lot of our health systems are based around the biomedical model, and they're based around what's easy and what's good for the healthcare system and not for the people it serves. Why measure patient-reported outcomes? So I think that's quite key. So I'll go into why we measured them, and then I'll talk a bit in more detail about what patient-reported measures are or outcomes are. So I think there are lots of reasons for measuring them, but one of the main reasons that I would say the top 6 reasons are: the first is about improving the ability to detect symptoms. This is very true in mental health, because a lot of mental health, symptoms, it's not like high cholesterol or blood glucose, where you can do a blood test, or blood pressure, where you can use this, you can measure it. So a lot of the measurement has to be done by talking to the patient. So this is it, and by using very standardized measures, it improves the ability to detect symptoms. And sometimes it also provides information that may have otherwise been missed. So this could be in medication adherence. If you're not asking the right questions, you may find the reason the person's symptoms are deteriorating is not because the medicine isn't working. It could be because they're not even taking their medicines. Another one is reducing dropouts. So a lot of times, patients, and especially older people, older patients may not show up for appointments. They miss their appointments. And there could be a whole host of reasons. And a lot of times, if you don't ask about the experience of care, if it was difficult to access care, it was difficult and they weren't treated right, or they were, sometimes it's things like too many of the stairs, there was no lift, so they couldn't actually get to their appointment. So using these patient-reported measures helps you identify the reasons why people aren't coming. But obviously, most importantly, is also it does improve outcomes. Because if you don't measure what matters to patients, then how would you know if your intervention works or what you're doing for your patient works? And as part of it, it's the shared decision making. So it gives that to have a conversation with the patient, to have a conversation with the community member about their mental health care. But I think one of the most important reasons, especially when you take a human rights perspective, is it ensures the voice of the patient or the person is being heard. And that is quite key in a people-centered healthcare system. The person or the patient, we are listening to them. We're listening to why they're seeking care. What do they expect out of their care? How would they like to be treated in terms of receiving that care? And also what outcomes truly matter to them in relation to their care. So what are patient-reported measures? Now, there are 2 types, and it's because generally it's information about the outcomes of care that matter most to patients and how users of health services experience care. So there are two components, as you can see on the slide. They are the patient-reported outcome measures and patient-reported experience measures. And they're quite intertwined. Some agencies like to keep them separate or have this kind of Venn diagram. But I feel the more and more I was working on mental health care, it is very much linked. So you can't really tease them out, because how patients are treated also affects the outcomes of care, especially in mental health care, we were finding. For instance, one of the things that a lot of clinicians and patients with lived experience of mental health illness were saying, that being treated with respect and dignity has a great impact on their recovery. So it's an experience about being treated with respect and dignity, shared decision making, and being able to understand what their practitioners telling them indirectly and directly affects their recovery process and the reduction of symptoms. So that's quite key, especially in mental health care, because I think in a lot of other ones, say for cardiovascular care or diabetes care, they're kind of, the Venn diagram works really well. But where I think with mental health care, the Venn diagram is pretty much non-existent, and it pretty much is overlaid on top of each other. Another key feature about patient-reported measures are they should be measured from the patient's perspective. So it's the doctor or the nurse or the pharmacist or the healthcare working asking the patient and then taking the answers. So sometimes they could be asking them face-to-face, or they could be using an online survey tool, or sometimes it's a paper-based tool while they're waiting in the waiting room in the clinic. So that's quite key, because a lot of times, from anecdotal evidence and some of the qualitative studies we've done, a lot of doctors say, oh, I just fill it for my patient, especially in mental health care services, where there are some standardized tools like the Kessler 12 scale and the PHQ-9 scale, where physicians and community health workers have said, oh, I just filled it out for the patient because I didn't have time to ask them that question. So then it's no longer a patient-reported measure if the doctor or the healthcare provider is filling it out. So that is quite a key element of patient-reported measures. So how do you go about measuring these patient-reported measures? So just to recap, I talked initially about what people-centered mental health care service looks like, and then how would you measure whether you have one and whether you've reached and things. So how you go about doing it is what I'm going to talk about next. So the first tip would be to take a problem-driven approach. So what do I mean by this? So what I mean is that a lot of times, a lot of things get dictated by national bodies or international organizations to start measuring things. But before, I think it's always good to take a step back and start to consider, what is the problem we're trying to solve for our patients and for our communities and for our clinic? So the problem could be anything, that there's a lot of patients are missing their appointments, they don't come back for their second or third appointment, or it could be things like the clinic or the community center has introduced shared decision making, and they want to see the impact of it. So I think before going into, oh, this sounds exciting, I want to start measuring patient-reported measures, really think through why you want to do it. What's the problem you're trying to solve with these measurements? And then from that would come a very clearly defined purpose for measurement. So once you know what your problem is you're trying to solve, you move into, what's the purpose of measuring this? So in the sense, you want to know, I've introduced a new shared decision-making tool. Does this improve the outcomes and the experience of people with mental health accessing my service? Or I've introduced community health workers as part of the provision of mental health care services. Does this improve the outcomes and experiences of care for my patients with mental health? So it's really good to have a very clearly defined purpose, because as part of the work I did, we were looking at all the lessons learned from various countries in implementing this. And this was one of the very, very much so one of the defining features of when patient-reported measures have been really successful in moving us towards a people-centered healthcare system. And lastly, focus on outcomes and experiences that matter to patients by asking and involving them. So what do I mean by that? So you know how I was saying that with patient-reported measures, one of the key features is you're actually asking the patient. So either face-to-face, verbally, or in a written form, or in an online digital form. There are even apps now to measure mental health patient-reported measures. What this is looking at, sometimes we use the same tools that have been developed in other countries or for other conditions, and we just kind of copy and paste and use them. What we found in our study was that it is really important for each country or region to actually ask their patients what are the experiences and what are the outcomes that matter to them, especially in this case, and even by condition. So for someone who has schizophrenia, the outcomes and experience that matter to them from their mental health, from the healthcare service, is very different from someone who is suffering from depression. Also, this is where the age element comes in as well. So the outcomes, for instance, for a young person who is suffering from mental illness, mental health issues like depression are very different. So for them, a lot of the outcomes, they want to be able to get back to school, they want to be able to hang out with their friends, they want to, so they've got those kind of, those are the outcomes that matter to them. Whereas for older people, sometimes it's the side effects. They don't like the side effects of particular drugs. They want to be able to see their grandchildren. They want to be able to do some gardening. They want the side effects reduced. And because they're taking a lot, they've got other illnesses, other comorbidities, it's a balance of their various medicines. So it's really important when you start on a measurement program is actually asking and involving patients and patient groups and ask and focus in what the outcomes are and what the experiences are. We did a similar exercise at the OECD at a global scale, and some of the concepts that were coming through are quite universal and some aren't. So for instance, being treated with respect and dignity, as I said earlier, was a universal concept that came through across the 36 countries as being quite an important experience measure. Another one was recovery, was also coming out, is getting back to the day-to-day lives, being able to do their day-to-day activities was also quite important. What those activities were quite different from country to country and from age group to age group, but it was that getting back to day-to-day activities. All the successful programs that have done this have all involved their patients and patient groups and clinicians quite closely in developing the measures. So just to kind of, at the end of the talk, I just want to recap what I've talked about. I started off with what is people-centered mental health care, and that is mental health care services that are based around the person. And I think this is even more important when you're dealing with an older population because they have a lot of other comorbidities. So how do we have a healthcare service that doesn't treat each person's disease separately, but in a conjoined manner, which is much more of an issue with an older population. So that's something to think of. And especially in practice, what would this look like in your healthcare practice by having a people-centered mental health care service? Secondly, I talked about why do we measure? Why measure what matters to patient and from the patient perspective? I think a lot of people argue that we've been measuring mental health all these years. Why fix something that's not broken? But the reality is our mental health care system in pretty much every single country. I don't think any country has solved it. So I think we need a new tact. And also it's about human rights. And it also has shown that it improves outcomes for patients and people with the lived experience of mental health. And lastly, I spoke about how do you measure mental health outcomes. So once you've decided that you're developing an integrated people-centered mental health care service, you know, how do you go about measuring whether your service is people-centered and whether you are delivering interventions and services that improve health outcomes from a patient perspective. So that's the end of my talk. I've got some references here for further reading. So the first one's the World Health Organization has a site which has a lot of documentation, a lot of really useful publications on integrated people-centered healthcare, and they've got separate ones for mental health as well for older people. The OECD documents on patient-reported indicators, I've got that website there, and that is more a technical document about developing these indicators. So the WHO documents are more of the framework and why and how we go about developing a system, and the OECD documents about how we go about measuring it. And the last paper I found very useful is about, and I think it really highlights the sometimes how do you take an international global concept and translate it in a country level, especially in a middle-income country like Timor-Leste, is are people-centered mental health services acceptable and feasible? So this is a really interesting article, and I would highly recommend you to read it because it kind of gives a more practitioner point of view. How do you translate global and national policies into at a practice level? Thank you very much. Hope you've enjoyed this talk, and hope you find these documents and readings useful and interesting in a way to ensure that you deliver people-centered healthcare services. Thank you.
Uh, th Thank you very much. My apologies for coming in late. My name is Akiko Maeda. I'm with the TUFH board and also a former colleague of Rabia. We work together in OECD, and I'll be moderating the rest of the session. So thank you, Rabia, for the presentation. I hope people found it stimulating. And so we open for a few questions. If you have any questions or clarifications or questions you may have about the topic. Would you like to raise your...
I'll get started if it's okay.
Yes. Yeah, please.
Well, first of all, thank you, Rabia. A fantastic talk. This is such a challenging issue because it's about something that's invisible. And we're talking about disorders of thought, disorders of mood, disorders of character that are the essence of who human beings are. And we don't have an extrinsic, a visible marker, first of all. So all you can, if I look at Akiko now, I don't know what's going on in her head, but it could be that there are thoughts that are actual serious symptoms. So there's that. But then the other aspect is that there's the human interaction element that becomes alienating for society and alienating for practitioners, because it's not only is it invisible, but it's also scary. The thoughts, the mental activity that this person in front of me might be having could be saying to kill me, or they could be saying anything else. So it's very frightening. And then finally, the last comment I'll make is that, Rabia, you talked about the concept of agency. So the concept of the person, the patient, being able to take action on their own behalf, that's challenging when there are disabling thought or mood or character problems that prevent them from acting on their own behalf, so that you end up in a situation where the practitioner ends up, or the family and practitioner ends up saying, look, what is in the best interest of this patient? And that's where we sometimes ended up with those monthly long-acting antipsychotics like Prolixin, where you just gave the medication and then you allowed the patient agency to take over when the patient's mood or thoughts or character disorders were under better control. But thank you. That was a terrific.
You're off. Rabia, you're muted. Would you like to take a quick jab at that challenging question?
Yeah. Thanks, Bill. No, it is a very challenging question, and I think that is one of the difficulties in developing a people-centered mental health service is, and as you've pointed out, where sometimes the person may not have the agency or may not have the capability of doing shared decision making or making decisions on their own account or things like that. So I think it is a very tricky exercise, and sometimes it is when, and I think that's when the family and carer component would come in terms of the patient. People-centered healthcare would be that it's not just the person themselves that you're treating, but maybe it's the rest of their family unit or their broader community, and how do you embed a system within that. But I think in mental health care, it is definitely very difficult, say, compared to and we found that with developing these indicators compared to my colleagues who were looking at breast cancer and hip and knee replacement. So they had a much easier job, I always thought, but also just because those are quite physical, um, rather than physical illness, physical disability rather than a mental disability. And I think, especially in aged care, I think it also brings up this whole issue, with, especially if you've got dealing with people with dementia or Alzheimer's. I think that's another whole issue, is how do you then have those autonomy, agency, shared decision making in in a population that's quite vulnerable, and how do you go about doing it? And I think we as a profession and as a group have to kind of come up with ways to deal with that. And I don't think it's going to be easy. And I don't think any country has, or health system has, solved it. But I think it's how do we approach this problem? Because it hasn't been working. I think that's much we know. But no, it'd be an interesting thing to delve into deeper.
Thank you. I see Nick has his hand up. Would you like to ask a question or comment?
Yeah, thank you. Thank you, Rabia. My question goes back to the outcomes versus indicators. And, I've done a lot of work on, the outputs, indicators, or outcomes. And I love this approach because the measuring mental health, right, and behavioral health is always so challenging. And we've never really been able, or I've never really been able to wrap my hands on it. But the focus on the outcomes experiences that matter to patients seems like a great indicator that leads to, I guess, positive mental health, right? Or something to that case. Is there, and we're getting in the naming between indicators outcomes, but is there any link or research that you did that links those indicators that say that by patients reporting on their outcomes or their experiences that matter to them in terms of what you framed, that has a direct correlation to their harder to measure outcomes? And the second part of the guy's question is, in any of your research or the literature, does it also say that mental health, these indicators also have any relation to health outcomes, physical health outcomes?
Okay. I'll answer the second one because it's easier. No, the thing, so that there has been quite a lot of research which does show quite high correlation between some of the mental health patient-reported outcome measures and, say, quality of life indicators and physical health indicators. So there is quite a strong correlation with that. In terms of the indicators, in terms of outputs and outcomes, and whether they're linked to hard outcomes, I think there's been a lot of work being done by in Denmark, looking at mental health outcome indicators. And what they did was they have a whole set of process and output and activity indicators, as well as very significant outcome indicator, which is inpatient suicide of people who've been recently diagnosed with schizophrenia and depression. And they had one of the highest rates in the OECD countries about 5-6 years ago. And as part of that, they started delving deeper and developed a set of patient reported measures, and to see if that could be like the canary in the coal mine, to see if they can kind of pick these things up earlier. And what was interesting about the way they went about it was they didn't just pick up any indicator or measure that was already available. They actually developed it iteratively and co-created process with patients themselves and healthcare professionals. And there was equal, so it was not one or two patients. It was actually, I think it was 20 patients, 20 health professionals, and they reached consensus on those indicators. And also these patients weren't patient reps or patient advocates. They were people who had recently had an inpatient stay in the hospital and recently be diagnosed with either depression or schizophrenia. And that model worked really well. I mean, it took them longer than say if they took something off the shelf, but they, I think, got a lot more buy-in. And also, I think it's now being embedded into the system. But I think it will take a while to see if that translates into their inpatient suicide rate coming dropping down a bit or not.
And is that was that in the report that you said in further reading on the slide deck?
Yes, it is. Yeah.
Thank you.
Okay, great. Thank you. Any other urgent questions? If not, I don't see any hands. If not, we'd like to go into the breakout session. I think you may have seen the 3 questions that Rabia had sent to you earlier. Let me just very quickly go over them. 2 are relevant to this topic directly. What outcomes do you think matters more to older people when they use health services? So that's one question. Second question is, how would you develop a set of patient reported outcome measures for the elderly with mental health? And then a more broad philosophical question is, what does successful aging look like for you? So these are the 3 questions that Rabia posed and that I'd like to have you discuss in your breakout group. So, and it's also in the chat if you forget what these are. Would you like to, should we have the breakout group, please? Hamza?
Was mentioned that in Japan it can help that the method of inquiry is done with presence of, for example, an animal that can lower the stress threshold of the person and facilitate also that he speaks out or he really expresses his needs. Another important aspect is also time, that you give the person time and kennis graag gezegd. And by excuses, my children are at home for the COVID. So, and that it's also important to have the time to really listen and to give time to the person to think about it thoroughly. Like also in a personal experience that I had with mental health problems with a patient in Belgium, is that you have to search, like with cognitive therapy, which things they still enjoy, which things they still feel that they give that gives energy to them. And that can be something very simple as having a cat and stroking a cat or things like that. But that's also very important that there's always a community perspective that makes it very difficult to have universal instruments of universal truth. Like I'm living for over 8 years in Bolivia, and there it's a very different perception what is being functional or having a life that's worth living. In some cultures, when people don't feel functional, they commit suicide, for example, as some cultural issue. So I think there's that the conclusion is there's no universal truth, but it's very important the method and understanding the culture also to do this inquiry.
Thank you, Christine. I thought it was fascinating with the indigenous culture that sets a whole different perspective. And I just wanted to add I raised a new question in me because these mental health prems are very individual oriented. The patient-centered care is also very individual oriented, which is fine at one level, but we are social animals. So how do you then expand further to more of that community or the family or whatever that grouping that the person is used to include that in that whole discussion? Because that is something that perhaps is not done systematically. It's a lot of talk about social determinants, but the term tends to then make it rather just almost like a checklist of determinants, when in fact those determinants are emotionally felt experiences. So those things are more philosophical issues, but I think very relevant in the design of the research, which I find still is very not public health, but very clinically oriented, which is patient, which gets into proms. How do we get out of that? These were just some of the thoughts that I reflect on.
Well, you also mentioned social context. I mean, I don't want to put Christine on the spot, but you have two beautiful children behind you, and it's just that's the social context in which you're working, and we must appreciate that and recognize that as part of who you are. And by the way, there's no need to be to apologize for the kids. We're all living through this, and it's an important way that we get to know you.
Yeah, absolutely.
Thank you.
We have just a few minutes as we're winding up, but any other comments, reflections for those who have not spoken yet? You're welcome to express your opinions, comments, any questions. No,
I don't want to put D
anybody
Street
else?
on D Street. I don't want to put you on the spot, but you're probably one of the youngest people here, and I'd be interested in your perspective on the aging concept.
Yes, I do feel a bit like a fish out of water here, to be very honest. Um, so the reason why I think this is very important, because in certain settings like ours, I was talking about this in the breakout rooms, we don't really have a framework to build on. We're still exploring perspectives, cultural taboos, linguistic barriers that come into play in developing a standardized outcome measure or experience measure scales when it comes to patients' mental health, be it in any setting, aging wise, or in a pediatric setting, for example. So it's pretty interesting to look at case studies from developed countries and other middle income countries, and it gives us perspective on how to take this further in our countries where it's a bit of a taboo to even consider discussing mental health.
And D Street, which country are you in?
So I'm currently in the United Arab Emirates, which is by definition a high income country, but culturally there is still a lot of stigma associated with patients seeking mental health and clinicians asking mental health questions in an OPD setting.
Indeed, and especially in the context UAE where 80% of the population is non-native, and that's a challenge to deal with, multicultural, but also
Exactly.
the labor rights issue. We won't get into that, but must be a lot of mental health issues there, but not that many elderly because they're sent home. Um, any other? Rabia, would you like to last word before we wrap up on your thoughts, feedback received so far?
Yeah, no, thanks, Akiko. No, I think this whole movement towards people-centered healthcare services is an important movement, and I think as people and everyone's at a different stage of their journey, and Akiko, as you mentioned, is we're still looking at the individual at this stage and not in terms of the broader context of their family, their community, and where they're kind of situated within that group. I think that would be quite an important way of taking this work forward, is how do we move from that it's not person centered, but it's more people. We're not individuals, we're not little islands kind of thing on our own. We are connected, and how we access health services does impact not just us as an individual, but other people around us as well. So I think that's quite important. And I think in mental health, and in aging, it's even more so than in other sectors because of, as I think Bill mentioned and Shiba and a few other people, in terms of there is that decreased agency, decreased autonomy at a particular, if you have that very severe mental health issues or memory issues, or and sometimes that happens with aging, the dementia. Then how do you then express your autonomy, and how do you report your experiences and outcomes of care? And that's when your family, and be it the fur family or human family, gets plays a role in terms of how do you communicate what you need and what matters. And I think one of the key things for me from people-centered care is that kind of shifting, that it's that we're shifting to make it easy for the person, make it easy for their family, but also shifting to things that matter more to the person. And I think in the healthcare system, we're very good at solving problems and solving diseases. And sometimes it may not be, the person may not want their disease to be solved. They just want to spend more time gardening, or they just want to um, be at home for the last days of their life, kind of thing. I think these are quite important issues. And I think as a society, as a broader global society, it's something we need to kind of think of is the health system's meant for its citizens, not for its policymakers and practitioners.
Yeah, great. Great, wise words. Thank you so much, Rabia, for sharing your experience with us. That was very, very helpful and fascinating. Thanks to everyone for sharing your experiences as well. Just very quickly, there are two other symposiums coming up on aging population series. So please keep note of the dates. You'll receive, I think Hamza has already given you the link to this video session. And reminder that the TUFH 2021 conference registration is up, and so please register if you can. And then finally, we invite you to respond to the survey, and we hope maybe some of you may consider participating or contributing to future symposiums of this nature. So
Akiko, if I could just add one more thing. It was
Sure.
Fascinating to hear from Dstri and from Christine. And it's not too late to submit an oral presentation for the Indonesia meeting. And if some of your experiences would be relevant, I think they would definitely be relevant. We would love to hear from you. What's the deadline? I think it's March 21st. March 31st. So please do keep that in mind, folks. It's wonderful, wonderful stories that we've heard today, and I really appreciate that.
Yeah, absolutely. Please share with us, and we really benefit from these exchanges. So Rabia, thank you for the presentation today, and thanks to everyone else for participating. My apologies for coming in a bit late, and saying bye-bye from my furball here, Momo. She's fast asleep. See you, everybody. Thank you.
Thanks, Rabia. Thanks, Akiko.
Thank you.
Thank you. Thank you. Bye.